Thanks everybody for joining this educational meeting, which is one of the national um, ones in terms of the HCCs coming together. So I presume that a lot of people would actually appreciate the fact that we all struggle quite a bit with treatments and how to manage adherence, or sometimes you might call it compliance, with the patients. So I'm just going to try and shed some light as to some of the areas that are quite important, and also some suggestions about interventions that we can offer um, as solutions for some of the problems and the challenges. But adherence is actually not a new issue. Certainly for those of you who I'm sure most of you would know Hippocrates, and especially the doctors amongst us, because it's an oath that they swear by. Um, he said back in the day that, patients often lie about taking their medicine. So even from his time, you could see that there was a problem about adherence. But in terms of what exactly adherence is how closely a patient follows the prescribed regimen, or the ability to take medication as prescribed. And I think that's the importance. So obviously, if you look at it, if the patient is not taking the medication as prescribed, then there is not adherence by definition. So we can't say that if they are, close to 100%, they are adherent. If they are not 100%, they aren't. But also, it has been recognized that about 1 in 4 people do not actually adhere with the treatment. And this is mainly because of side effects, concerns that they might have, and also practical issues that are 3 of the main reasons, but there are several. And also the WHO estimates, this is something that was referenced many years ago, but I think it's still valid, because when I checked the WHO's website, they hadn't actually updated any figures to suggest the contrary. That about 50% of patients with chronic diseases do not follow treatment recommendations, and I suspect there are several reasons for that. And also, the 3 main ones that I've mentioned in terms of side effects and their concerns and practical issues and so on. But also in the UK, there was a large study that was done in Birmingham, Aston University. But again, I checked and this hasn't been updated, so I presume that it is about the same in terms of costs. So non-adherence costing the NHS about £500 million a year. That is very significant. When I look at adherence, I want to break it down into several categories of factors. So the first one being patient-related factors. For example, sometimes attitudes and beliefs about the actual treatment or the medication. There are perceptions of severity and also expectations from the treatment. The perceptions of severity is very relevant, because I think sometimes, even in terms of patients with sickle cell or thalassemia, if they are getting a good response from the actual treatment, the perception of severity changes. So over time, they might have severe sickle cell disease or thalassemia, and then they might perceive that with the treatment, they are no longer severe. So for example, patients with sickle cell disease or on hydroxycarbamide might not see a lot of painful crisis. The perception of severity changes, and they become non-adherent. And also expectation of treatment, I think, are quite important. Well, I'll have some examples of that as well. The second category is therapy-related factors, which are basically the things to do with the actual treatment itself. So for example, the frequency of dosage, or the complexity of the regimen. So if you take something like even penicillin prophylaxis, which patients have to take twice a day, you know, just having to take it twice a day as opposed to once a day is going to cause problems with non-adherence. And sometimes we do have treatment regimens that are quite complex, and a lot of patients may be combining different types of treatment, you know, which even adds to the complexity. And I'll have some idea, some illustration of that as well. And then the third area is what I call condition-related factors. So depending on the condition itself. So if it's an acute episode of some like pain, or acute episode of some, you know, complication, then, you know, they have to take medication for a short period of time. For example, we are treating patients with antibiotics. And even then, sometimes, you know, adherence becomes a problem, especially, you know, maybe outside the hospital setting, whereby they are asked to carry on with that treatment. But when they're in the hospital, because they are kind of monitored more closely, they might adhere to it for a few days or several days or whatever. And then, you know, when you have a chronic disease, and this is not probably even restricted to the hemoglobinopathies, you'd have patients with diabetes or heart failure having to be on long-term treatment, and that becomes a problem. And also, I think the physical state of the patient, the actual, you know, in terms of how they feel physically, whether they are in pain or whether they are, you know, able to function on a day-to-day basis, that kind of affects that. And importantly, also from a psychological point of view, their emotional well-being. And there is evidence to suggest that when patients are not feeling very well psychologically or emotionally, they tend not to adhere to their treatment. So, for example, if somebody's depressed, they're likely to miss doses. If they're anxious, equally the same case. And then there are demographic factors as well. So things like age, gender, socioeconomic factors, culture and religion. Age, for example, we know that with children, because there's more close monitoring by the parents, and actually the parents administering the medications or the treatment, that makes it easier. As they grow to become teenagers, we know there are issues there because they don't necessarily take responsibility for their own medications or treatment quite in the same way, and those might be adolescent-related issues and so on. And then there might be some gender factors, especially men sometimes feel that, you know, they can do without the medications, and there's a lot of evidence around other chronic diseases as well to suggest that, you know, men tend to miss doses more than women. Socioeconomic, sometimes we don't even think about it, but I've heard patients say, you know, I can't afford, you know, the medication, and sometimes in the prescriptions, we know there have been issues around getting free prescriptions for adult patients. Parliament has been lobbied to no avail. There's been several petitions over the years, and we are still in the same place. But there are other things that sometimes people say that they don't have money for transportation. Typical example of a young person recently lives out of, you know, sort of our catchment area, but is still coming for his treatment. And he told the senior nurse responsible for managing, you know, transfusions and stuff that he doesn't have, you know, the funds to actually come to the hospital for his treatment. So these are kind of real things. And also, I think there are cultural issues, and sometimes there are religious issues that might interfere with the treatment. And that is something that is quite significant that we need to look at as well. And that feeds into the beliefs and attitudes that I was talking about. But non-adherence, you know, also has implications. There are multiple issues, some of which are the worsening of medical conditions. We know that. Also, patients would have unnecessary complications. And overall, there are higher rates of morbidity and mortality. So basically, if you're not taking your medication or your treatment, things get worse, and in some cases, might be quite fatal. I don't think I need to give examples of that, but I'm sure we've all experienced, patients not adhering to their treatment and then obviously deteriorating as a result of that. In a lot of cases, for example, with thalassemia, you might find, iron overload, patients are not chelating properly, and then they do get, severe problems with liver, heart, especially heart failure in those cases, and those are quite serious. Nonetheless, non-adherence also, from the point of view of NICE, and this is the NICE guideline, also not updated recently, that actually non-adherence to treatment is not only the patient's problem, but it's actually a fundamental issue in terms of treatment delivery. So we are kind of all responsible. And in a way, these two areas overlap to say that, if we are delivering healthcare, then we need to make sure that the patients are receiving the treatment that they should. And therefore, we can't always say that, well, if they don't turn up for their treatment or they don't take their medication at home, we are not responsible. We are equally responsible for that. And again, I would categorize that there are two ways in which we can look at non-adherence. One is unintentional non-adherence, and then also intentional non-adherence. I'll talk a little bit about that. And sometimes patients move from one sort of state of, let's say, unintentional non-adherence to intentional non-adherence. So let's look at unintentional non-adherence, which is basically barriers to treatment beyond control, beyond the patient's control. So there are things, for example, recalling, forgetting, understanding, practical difficulties, financial constraints. I've given a couple of examples of that. But if you think about it, sometimes, for example, we might have patients with sickle cell disease tend to have complications, neurological complications. So be it silent infarcts or silent strokes or strokes per se, or even without those overt clinical manifestations, we still do see that there is cognitive impairment. And if there is, there are problems with memory, there are problems with executive functioning or abstract thinking, as well as, problems with, let's say, learning. And this would apply with children equally, as well as it will apply to adults. So what we have to remember is that if we are not sure, we need to assess the patients properly to understand and make sure that we find out that there are no complications, no neurological complications, for example, that are interfering with the treatment, because that would be something beyond their control. The other areas that I think are very important is that, obviously, if the patient hasn't got the comprehension, we need to make sure that the information is in a user-friendly format. And we try and do that with a lot of patient information leaflets, but sometimes it may not be the case that everybody understands the information. We need to break it down further. I've talked about practical difficulties and some of these financial constraints that people may have. And some of the practical difficulties might be just in terms of, people's lifestyle. And sometimes it's not intentional that they might have to work. They might have to, for example, they might have to leave home very early. They might have to come home quite late. And there are kind of practical things that probably in terms of the treatment, we need to support them and identify those areas and dealing with that. And obviously, when there are financial constraints, whether they need support with benefits like DLA for the children and PIP for the adults, those are things that we need to look at in terms of supporting. I definitely have evidence of patients who talk about not even being able to afford prescriptions. And that is quite serious, that if we are prescribing all these medications that are supposed to make them better, we also need to support them in terms of their finances. And again, looking at intentional non-adherence. This is when the patient actually decides not to follow the treatment recommendations. And sometimes, again, as I said, there might be some beliefs or perceptions. After all these years, I mean, we've had some patients that have been on hydroxycarbamide for 25 or more years, because some of those were right at the beginning. I think still hydroxycarbamide hasn't got street credibility amongst a lot of patients. And it's very difficult to break that barrier, simply because a lot of people get information from social media and other sources that are incorrect. And sometimes it's almost impossible to know where they're getting the information from, but it's easy for them to influence other people. I mean, we've had examples of the COVID vaccinations, but for something like hydroxycarbamide that has been around for a long time, that for the majority of patients that have had a good response, that actually changed their quality of life, we still have issues around their beliefs and perceptions of a significant proportion of people that it's quite difficult in that sense. Side effects is also one thing, and whether they are new medications or existing ones, again, if patients get side effects, they do, stop to take the medication. But sometimes they don't actually tell us. So, for example, if they start any treatment at the beginning, whether it's XJ, whether it's hydroxycarbamide, as typical examples, the initial side effects that they might get, because it might be something minor, that the treatment could be either stopped or the dose they reduced if they don't tell us. It's difficult to help them to adhere to their treatment. And also, importantly, the motivation to start and the motivation to continue. At the moment, we have some new treatments, as you all know, crizanlizumab, voxelotor, but I can guarantee that the issues of non-adherence are going to soon start cropping up. There's always the initial enthusiasm in some cases with new treatments where we haven't identified any significant side effects at the beginning. But behaviorally, some of the challenges, and also perceptually and practically, some of the issues of non-adherence would come to haunt us again. So I just wanted to take us back historically, and if you just think about it, using some examples. So I think we all remember dexferoxamine, years of having this very difficult ion chelator, for which just looking at some of the patient-related factors that patients at the time were complaining about, and we should remember that there are some patients who are still having this treatment. A lot of thalassemia patients are having this treatment for various reasons. And obviously, people talked about the fact that it was cumbersome and demanding, still is, basically in terms of the administration of the pump or the syringe driver. There's discomfort of repeated needles, and then also you had hypersensitivity, at the injection sites. In terms of the therapy-related factors that were also have been reported, is the burden of chelation therapy or the complexity of the treatment regimen. And if you remember, sometimes, some patients have to have it for several hours overnight, and in some cases they still had to carry it, during the day, and this would vary from week to week and so on. It was such a big burden. And so what happened next? Everybody thought, XJ, an oral chelator, if you remember, at the beginning, it was the dispersible, and then more recently, we have the tablets. But again, going back historically, another time I was, trying to study some of the differences between dexferoxamine and XJ. You could see that straight away, the problem of adherence, patients started to complain about the same thing. They talked about side effects. They talked about the unpleasant taste. There were, interference with their daily activities and time constraints, just simply because, if you remember, they had to dissolve the tablet in a glass of water or something, wait for a period of time, before taking it, even though it was quite short. And then some of the therapy-related issues they talked about, again, the time to prepare, not easily dissolved, and the full dose was not taken. And so obviously Novartis, the company that was, that developed this drug, they looked at, making it easier. But just by comparison, there was one study which I thought was quite interesting. This was a study in thalassemia whereby they looked at chelation therapy, because I remember at one of the early meetings that I was invited to at the launch of XJade, probably it was a meeting in Philadelphia. I just told sort of everybody in the room that I think the problem about adherence is not necessarily just a simple one. And this study actually highlights the point. So in this case, there was a comparison of patients on Desferal versus XJade, and they looked at what you call self-reported adherence. And obviously in the XJade group, it was just slightly higher than in the Desferal group. And so you can see that the differences, so this is self-reported adherence and self-reported adherence over 90%. And I think statistically, the difference was very small, but it just highlighted the point that actually the high reported adherence of dextroxamine suggests that the route of administration of the treatment may not be a key to non-adherence. So basically what it's saying is that whether it's by, the infusion, like an injection, which was burdensome, or whether it was by just an oral method, that's not necessarily, make it that, the easier route of the oral will make patients more adherent. And I think it is an issue that we are facing at the moment with XJade even as a tablet and easier than Desferal, but some patients actually, for various reasons, like I said, still utilize the pumps and Desferal for their treatment. And again, now we've come to hydroxycarbamide. We have the tablets, obviously, and then we also have more recently the Exromi for the kids. The kids have always had a liquid kind of suspension, which was made by pharmacies in the different trusts. But in this case, the company has come up with one that has a longer shelf life and it's easier for everybody. But again, the issues at the time, also studying this sort of issues around hydroxycarbamide, is basically that patients reported more or less the same thing. The safety and the side effects that I've talked about, perceived severity, again, when patients perceive that their severity of their condition is less, and the same issues, frequency of dosage and complexity of the regimen. And again, they sort of mirror more or less the same things that you're finding with other treatments like the ion chelators. So this is a slide that was lent to me by a colleague in France. Some of you might actually know her, Marianne de Montalembert. And she, in their study, I think a colleague led the study, it was about 1 out of 3 patients taking hydroxycarbamide every 2 days. So straight away, that shows a huge number of patients not adhering, because if you're just taking the medication every 2 days, you're definitely not going to get any the maximum benefit, put it that way. But 1 out of 3, that's a huge number as well, 30%, close to. And some of the reasons why they gave for non-adherence, there's a literal French translation, I think. They said omission. I think it's just that, they missed the doses by forgetting or something. Wariness and also side effects were quite important. But by comparison, they had also reported in relation to hydroxycarbamide, you have folic acid as well as penicillin, and you can see the differences. Actually, folic acid had a very high non-adherence rate, but that of the penicillin was similar to hydroxyurea. And again, so just to put this all together, non-adherence in terms of the psychological challenges, I like to put psychological things in terms of people's basically thoughts, feelings, and behaviors. It's a kind of like a model that I use for psychological interventions. So if you look at the thoughts and feelings, there are additional areas in which, when people are feeling vulnerable, and that is actually when they are feeling, you know, in a situation whereby they are not managing, but it's a bit ironical because when they are not managing their condition very well, both in terms of either sickle cell disease or thalassemia, for example, then they are more likely to have difficulties in adherence. And also, I've talked about the denial of severity, and chronicity is a word that I kind of use in terms of not that we know that these are genetic conditions and people are born with them, but sometimes the chronicity of the complications, that is basically how long people are having difficulties, because as you know, in some cases, things are quite smooth for a while, and then all of a sudden there are complications. And so for that chronic phase, and even if you want to put things like pain and stuff in terms of sickle cell, for example, it's how that phase of having chronic pain and so on. But mood and in terms of anxiety and depression are also very important and quite sort of prevalent. And then in terms of the behaviors, it's about people's coping ability. Sometimes truly people can't cope and they need support for that. But I've talked about the fact that also as children grow to become teenagers and young adults, that issue of autonomy and their limitations that they might have or that of their parents has an important effect on their behavior. So psychologically, I think we need to look at that. Then in terms of lifestyle and quality of life, I think that is also quite important because a lot of young people don't want, and this includes some of the young adults as well as teenagers, they don't want any interference with their lifestyles. And and the interesting thing is that sometimes if their quality of life is not too bad, it's good, they actually feel that the treatment has more interference in their lifestyle and quality of life. And then out of it, all of a sudden, or out of the blue, they get complications and it becomes a problem. So from a psychological point of view, these are kind of the key areas in terms of challenges that we need to try and identify. So again, going back historically, and this looking at a couple of models in terms of adherence from a theoretical standpoint and trying to understand, though this model, which is the Lay's model of compliance, which is basically looking at what patients understand, comprehension, memory as well, on the other hand, and these two key areas would influence compliance. But what was looked at in terms of being the mediator, so you could have understanding and compliance, understanding and then memory issues as a broad category, and then leading to compliance. Or in terms of a mediator, then, sort of satisfaction was thought to be one of the key things. So first of all, the patient needs to understand what the treatment is all about. They need to be satisfied, and then they would comply, more or less. The second thing is that the patient actually needs to have a good memory, needs to remember the treatment regimen. And if they do, they are satisfied, and then it would lead to compliance. So that was more or less the model in its simplicity. But more recently, this is one of my favorite models, the health belief model from a psychological perspective. And this is basically a model that tries to explain and predict health behaviors with a focus on attitudes and beliefs. And within that model, you have something called illness perceptions, which is, again, as I mentioned, the degree of severity or seriousness, how much personal control somebody has, and also how self-efficacious the individual might have. And putting it in simple terms, so this I have adapted this from a publication. So the perceived threat of disease, as it is defined in terms of the model. So how threatening a condition might be. So that, again, that perception of severity, leading into the likelihood of behavioral change. So if somebody thinks that their condition is, let's say, life-threatening, then they are likely to change their behavior and become more adherent. On the other side, you have what you call perceived susceptibility or seriousness of the disease. So again, related to the threat, you have what is, can be looked at as the severity. Or if you apply to other conditions, then whether they are susceptible. And that might apply to something like COVID. If somebody thinks that they are susceptible, they are more likely to maybe take a vaccine or adhere to it, and in terms of the severity of the problems. And then there's something called cues to action. These are basically things that will prompt somebody into looking at, that perceived threat. And again, you have demographic factors that you look into, like I said, age, gender, ethnicity, personality, socioeconomics, again, knowledge, which is basically understanding of the condition. And these feed into the model in that way. And then also the demographics lead to what you call perceived benefits versus barriers to behavioral change, which is essentially with the demographic factors like the age or the socioeconomics or the understanding, people might see the benefits of a treatment, or they might see the treatment as actually as a barrier. And some of these demographics would be the barriers to the behavioral change from the examples that I've already given. And so I'll just run through very quickly. I'm not going to go into detail with the case, but I just want to highlight a few things. So this is a case whereby you have a young person, a teenager, started hydroxycarbamide at the age of 3 for multiple pain crises. At the beginning, had no hospital admissions for 3 years, but then the unintentional non-adherence kicked in. There was a very complex treatment regimen at one point. Obviously, growing from childhood to teenage years, forgets to take the medication. And as I said, lack of parental supervision when teenagers are becoming more independent. And this is an example of the treatment regimen at 1.500 milligrams, Mondays, Wednesdays, and Fridays, 1,000 milligrams, Tuesdays, Thursdays, Saturdays, and Sundays. So taking one tablet 3 times a week, but every other day, and then 2 tablets again every other day and other weekend. Quite a complex thing, and sometimes people find it difficult. But again, not going into too much detail. I've hidden some of the years to try and so that we don't reveal too much about the individual. But as you know, hemoglobin F percentage is a marker of adherence. And also you can use hospital admissions as another surrogate marker, so to speak. So at the beginning, when they got a very good response, you can see it was about 19.7 F percentage, 19.8 thereabouts, with about 2 hospital admissions a year. And that was, sort of the trend. And then at some point, they started to have problems, and immediately the HbF percentage dropped, which was an indication of non-adherence. Hospital admissions went up. So you can see, and then when they started again to adhere, hospital admissions kind of stayed down. It went back to 18.9%, and again it dropped as adherence became a problem, and it dropped as much as to 5.6% with 9 hospital admissions in the last year. So again, trying to look at interventions in terms of improving adherence. There's a model which is a 3-factor behavioral model, quite simple, combining patient education with beliefs and motivation, looking at barriers to treatment, and it's all interlinked in one way or another. So if you want to look at the first area, which is patient education, as I talked about, improving communication is very important when we're trying to educate patients. Listening to their concerns. If you do, they are more likely to tell you the truth, and then you know how to sort of intervene. You encourage participation in terms of the decisions, and then also you try and build that trust and empathy. When it comes to beliefs and motivation, obviously you try and help the patients to believe in the treatment, trying to identify some of the social and cultural factors that are, responsible for, those kind of beliefs. Very important to do that. And then we try and, obviously change their attitudes and treatment perceptions. And then you motivate commitment. These are all not very easy. It takes a lot of work. It takes, the everybody in terms of an MDT, so not only the hematologists, the CNSs, nurses, community nurses, psychologists, everybody plays a part. And also, obviously, in terms of the barriers to treatment, you can look at some of the psychological aspects of it. So, whatever therapy that can be offered, in terms of dealing with their emotional problems would help. We try and identify and enhance social support is very important. And again, as I mentioned, help with the treatment and other finances, and also in terms of recall. These days, there are a lot of different ways in which you can offer therapy as well as you can offer support and also deal with. I mean, there's so much with smartphones and apps and so on. Another area that a lot of people use in terms of a psychological intervention called motivational interviewing. This is basically, in a nutshell, what you call the stages of change. Is like somebody starts, you want to start somebody on a new treatment, they contemplate, and then they become prepared, and then they, obviously start that. That's the action, and then maintenance, staying on the treatment, and sometimes there might be relapse. And then feeding into that is that actually at the beginning, there's something called a pre-contemplation phase. That is even before they start to contemplate. So you give them that information initially, and then it takes them a while to even start thinking about the possibility. And that's where sometimes we do have challenges. And then also when they start the treatment or the medication, it's being able to endure that change in their lifestyle. So in a nutshell, that's what it is. I mean, it's quite a popular intervention, so I thought I'd highlight that. But it takes quite a bit of time to get into it in terms of working with other people who might want to utilize that intervention. Now, in recent times, like I said, a lot of utilization of things like what do you call digital health or mHealth, behavioral interventions. So we know there are lots of apps. You can use it for medication adherence, patient education, pain and symptom monitoring, coping skills, and even in terms of one of the popular psychological interventions that some of us do use, cognitive behavioral therapy, CBT, and so on. So this is just the first two at the top, just a snapshot of an app that we developed a while ago with funding from Novartis. Is no longer functional. It's just that we used it for a study. And it was just to monitor patients. So you can see the first couple of questions. Have you used your XJ or Desferal in the last day? Simple yes or no. Did you have difficulty in using it? Yes or no. And we had some additional questions with that. I'm also aware that TIFF and others, the Thalassemia International Federation and others have, sort of developed apps and trying to use that to help with things like adherence or education and so on. So it's important that we do try and utilize some of these digital health technologies or mHealth technologies that might be mobile health technologies that might be available. And again, just to highlight quickly that during the study, we had a period of time where with the app, we gave every patient who participated in that arm of the study an upgrade on their on their smartphone, and then also they had the app on their phone. If I'm correct, I think one of my previous colleagues who is now working in Lewisham, Hannah Grocott, was involved in the study. And basically just looking at it. So the intervention was just using the app without any sort of other input. So they had the app on the phone and that was it. And so every day they had to go into the app and record, their responses. If they didn't, they would get a reminder at 8 p.m. If they didn't, they got another reminder at 9 p.m. and that was it. So this is a typical thalassemia patient, for example, at the beginning. So the first question is a yes and no answer. Have they used the chelation therapy? So basically, at the beginning, she wasn't actually too bad, but so she wasn't really sort of adherent. She was missing doses, and then her serum ferritin went up, and then she started. So this is yes, using it, yes, going down, and no over here, and then over time, right to the point whereby she was very adherent, I would say, because her ferritin level dropped to the level that we kind of wanted to be, more or less. So in summary, treatment adherence is basically in terms of addressing adherence is very important. We know that it is crucial, but it is very difficult. And one has to look at all the strategies that we can adopt as a team, MDT. But patients need to be motivated and supported. We need to actually identify what the issues are, and hopefully, truthfully, they'll tell us. And then we look for interventions that would help with their daily needs and so on to help improve that. I'm very interested in using technology as well in terms of trying to see how we can use that to help. And just to finish off, had a recent publication with two colleagues at the Whittington. You might all know Farah Shah, but also Chiney's psychology colleague over there. This is open access, so it's just free to download from the internet. Thank you.
There are a few questions in the chat. One comment that from Catherine Stevenson in Manchester. that the patient had advised her that he didn't comply with his treatment because it was a reminder that he had a disease and he wanted to forget about that. Is that a phenomenon that you recognize?
Yes, but probably in different ways as well. So if you remember when I talked about the severity of the condition, is basically that obviously that person is trying to deny what they had, and sometimes the denial is not only completely, but also it could be that they are denying that it is something severe for which they need treatment. And unfortunately, what happens is that, they might get away with it for a bit of time, and then eventually the complications will set in.
And then another question from Eva Tuana, as to whether they're validated adherence tools, questionnaires specific for hydroxycarbamide for sickle patients and their carers.
Not really. I mean, I looked in the beginning and there wasn't anything that is validated, but some of the validated tools that are available, I think, can easily be applied. For example, the illness perceptions questionnaire is one of those, and then I think there's something about the medicines. I've forgotten exactly what it's called, but it's about medication and people's perceptions about medicines that could easily, you could just adapt for something like hydroxycarbamide because they are already validated. All you need to do is just substitute the term for the medicine with hydroxycarbamide or whatever you want to use it for.
Yeah. Thanks. And from Rabina Malik, a question which I guess mainly relates to pediatrics, which is, when does non-adherence become a safeguarding concern?
Well, I think for something like penicillin, for which, it is a standard and also there is that grade 1 evidence, that I think we always take it seriously, that it should be a safeguarding concern. For something like hydroxycarbamide, it depends on, again, how severe the child might be, or even in terms of transfusions, how severe the child might be, that, you might say that, the denial of treatment for the child will be a safeguarding concern. So I think in both cases, we need to take it very seriously. But as you know, I think with penicillin, they have actually demonstrated in the UK screening data that non-adherence causes death.
Then from Mamta, which you touched on earlier, actually, when will prescription charges be exempt for sickle cell and thalassemia patients? This is a long-running battle, isn't it? Over the years, many attempts have been made on the basis that there are other chronic diseases like diabetes and I think several others.
I know it's something that is still being discussed, but unfortunately there hasn't been any change. I mean, we have the all-party parliamentary group, and it's a bit of a shame that on the back of all these issues that have been highlighted within even the recent APPG report, they haven't used it as another way of trying to help with the prescription charges, because definitely it's a significant problem for some patients.
Yes, it didn't feature at all in the APPG report, which had a rather different focus. But it'd be a pity to lose momentum on that, really. And there's a comment from Christiana Diner about investigating patient acceptability of an intervention at the research stage. So this,
Yeah.
Christiana, do you want to just clarify your question or comment for Kofi?
No,
so I don't misrepresent it.
Not a problem. I work with Kofi, and I was just saying that one of the things we've realized with adherence is also acceptability of the intervention to patients, similar to what you alluded to, Kofi. So if we think about that at the start of the at the time of research, of actually designing the studies, then at that time, hopefully, you can actually identify issues that patients might actually struggle with at that point, and actually make adjustments at that stage.
Yeah, I think it's a very good point, because, well, I've been involved with some of the early research and also some of the early developments around some of the treatments for both sickle cell and thalassemia, and I think that's one of the things that seems to be important. Unfortunately, in some cases, just depending on the type of drug that is being developed, we can't always achieve that. For example, there's one treatment, I think it's L-glutamine. They really struggled in terms of the dosage to try and make it, easy for patients, but in the end, probably they couldn't achieve what they wanted. But yeah, it is an important point.
Thanks.
Kofi, do you think there is more that we could be doing as the sort of hemoglobinopathy clinical community to counter the misinformation that abounds in social media?
Yeah. The unfortunate thing is that we are not, in a way, invited into their social media circles, put it that way. But maybe we should find a way of being able to, even if there's a support group or whatever, which is basically what happens a lot these days, a support group just strictly on social media. We should be able to find a way to be able to get invited to give them the correct information. Because like I said, hydroxycarbamide is one of those that, unfortunately, even though it's been around for a long time, I've had, over the years, at least a few families have said they've had to come out of the support group because they wanted their child to try hydroxycarbamide, and the support group was so negative. And even some of those were actually, support groups that would meet face-to-face in person. But I think more recently, especially with the WhatsApp groups, it's very easy to circulate misinformation as opposed to getting the correct information from professionals like ourselves. So I think we need to do a lot more than we're doing.
Thanks very much. And another question from Rubina: Do we have pediatric patient support groups who can talk to the parents who have had difficulty in adherence now that many more children are being treated with hydroxycarbamide?
Yeah, I think there are some around, and I also know that some of the groups are on social media as well. They might not be formal in terms of representing, maybe a trust or something like that. They are more like, just independent. Because what I know is that before COVID, there were groups of patients who went on the sickle cell holidays, and then they started their own support group and so on. And then they tend to be more on social media, but I know that those groups do exist. And whether, some of the parents are involved or not, it's difficult to tell, but yeah.
I think Rubina was suggesting that within pediatric support groups, there would be parents whose children had benefited from hydroxycarbamide, and whether they could act as advocates or support for
I think
those parents who
I think that could be the case.
Hesitant
as well. Yeah.
And presumably over time, the sort of cohort will change, and as more children who've received hydroxycarbamide transition into adult care, then perceptions may impact on that population as well.
Exactly.
Okay, well, if there are no further questions,
I think there was a hand up, Oluwilki, I think.
Yeah, I just had a comment about what you were just saying about the parents groups. I think they're very powerful when you have a parent who's been on hydroxycarbamide and it's just changed their lives and the life of their child. I think that's probably the way forward in trying to convince a lot of our patients, because that's happened just on the ward or in clinic. In my hospital, if parents meet and just talk, and there are some that are very skeptical about hydroxycarbamide, then change their minds when they speak to another parent. So that's happened a couple of times. And so I think that that's a very powerful way to try and convince some parents.
Thank you. At
one point we had a group of so just before COVID, we had one very large group of children with their parents on hydroxycarbamide, and one of the children, well, two of them actually, they agreed that they gave like testimonies, and they agreed that we could make like video clips. So that is the sort of thing that we use to sort of encourage other parents, just hearing from, a child who's been on hydroxycarbamide for X number of years and so on. But yeah, it's very, very, it's a powerful thing to get others who can actually convince, especially the parents, to allow their children to have it.
And I think there was a question from Indu.
Hi, I just wanted to ask if you had any tips to sort of, how to gain confidence of teenagers.
I think one way is that if you have any of them who are prepared to speak to the others, a lot of times they don't, but if you're able to get maybe one or two of them that are able to speak to the others, it's easy, because it's like peer to peer, and they tend to listen to their peers more than others.
Thank you.
So if there are no other questions or comments, just remains to thank you, Kofi, for that enormously helpful and insightful presentation, which I think gives us all a lot of food for thought in terms of how we approach this in our patients. Thanks on behalf of everyone.
Oh, sorry, I just remembered something. When we're in places where you think a child or parent are not adhering to medication, do we normally send them to a psychologist? Because that's what we're trying to do in our trust, when you do have the psychological support. But obviously in most places you maybe have 0.2, or you don't even have a psychologist at all. So I just wanted to ask that question. Do you do that in your trust?
Well, I think it obviously helps to get input from all disciplines, including psychology. But at the same time, I think it's also that I think that, the people who are able to spend a lot of time with the patients, and that includes psychologists, but also I think like the nurses sometimes might be able to get a lot of, information, than deciding, who would handle it best is probably the approach to use if you're not necessarily having enough psychological support.
Thank you.
Okay, so I think we'll bring the session to a close. And again, thank you very much, Kofi, and for all of those for joining us today.
Thank you.